A 26-year-old male presents to ER with a tug of omentum protruding out from the abdomen following a stab knife injury. On examination, I'm not interested about the question now. It's a penetrating injury with evisceration. Let us see. The vitals, pulse is 88, BP is 180, respiratory rate is 16, GCS is. Now, if you see, this is a patient with penetrating injury, but hemodynamically the patient is stable. What to do now? I care a damn about that. I need to explore this because this weapon, why the tug of momentum has come out? Because someone has stabbed and when the knife has been receded back, the momentum has come out. But this momentum could be concealing an injury. There may be a concealed injury. Right now the patient is stable, but patient may develop a feculent peritonitis maybe after 1 day. And that time the salvage is minimum. So remember, a negative laparotomy is justifiable, but negligence is never justifiable. So let us try to understand this quickly. If we talk about this concept of approach to abdominal trauma, the first thing that you need to understand is what is the nature of injury. Whether it is penetrating injury, or whether it is a blunt trauma. When you talk about the penetrating injury, the next question that you have to understand is whether the patient is unstable or whether the patient is stable. Because if the patient is unstable, then you will have to go for exploratory laparotomy. Surgery is the call. Basically, surgery is the call. If the patient is stable, what to do in this case? In this case, you will have to go for CCT. The important thing is penetrating injury with any of them. What do you mean by any of them? Answer is impaled object, point number 1. So impaled object. The second is evisceration. Third is peritonitis, bleeding via natural orifice, and gunshot injury. In all these cases, the priority is always, yes, in all these cases, you will always have to go for surgery irrespective of the status. Remember, CT is only 70% sensitive in predicting the injuries. What about the 30% false negative reports? You miss the patient if you miss the injury. That is what is the rule. When you have the blunt trauma, here what to do? Check whether the patient is stable or unstable. If the patient is blunt trauma with stable injury, yes, you'll have to go for CCT, because CT scan is the best modality for screening abdomen, and since they are stable, they can be transported to the radiology department, because CT machine cannot be brought and move. Portable CT is not there. When you talk about unstable patients, what to do? You'll have to go for fast, because now here you have to decide whether should you go for surgery or should you continue with the conservative management. So fast will help you decide, or rather nowadays we go for e-fast. If the fast is positive, then you will have to go for surgery. If the fast is negative, then we'll have to go for repeat fast. And when you go for repeat fast, if this time it is positive, then fine. If it is negative now, that means you are missing a retroperitoneal organ injury. So in this case, you will go for serial PCV and hemoglobin monitoring estimation. Do you know, in this case, if you see that it is decreasing, that means there is ongoing blood loss, and therefore surgery is the call. And if it is constant, then observation is the call. So if you go to this question without reading anything, I'll go for exploratory laparotomy as the answer.